Dear colleagues, welcome at our conference. In the Presidium, we have Tal Horer, the President of EVTM Society. This is out of the mic. Очень плохо. And please check, folks, take your seat at the Presidium.
Please take a seat. We have a tight timeline, tight schedule, and we should start with an opening speech, opening talk from Deputy Chief of our Military Medical Academy, General-Mayor Kotev.
General Major Kotev and Professor as well. Please, the floor is yours. Очень плохо. Просто отвратительный звук. We go live today, so dear colleagues, dear friends, allow us to open this conference all together. Maybe a such scale conference is taking place for the first time in St. Pete, with the participation of leading centers of our city and many specialists from abroad who arrived to us. And the conference is dedicated to many invasive solutions and endovascular solutions in traumas and bleedings. This technology has been used very broadly in civilian surgery, and vascular centers that are working very well help to cope with very serious problems that are connected with diseases and complications of surgery, advanced cancers, and many other systemic diseases. But all advanced technologies certainly are developing all the time, and by the efforts of many specialists, first and foremost in the West, but now in our country as well, these technologies are being developed at the front line of providing medical care to wounded and people and victims of military and terrorist acts and local military conflicts. We are very thankful to our foreign colleagues, Umbrella Barra Society members who have arrived to St. Petersburg, and I think that today's platform will help us to form a new area of the development of these technologies. On behalf of the management of the Military Medical Academy of St. Petersburg, allow me to welcome all the delegates and wish you a fruitful discussion, successful work, and also get acquainted with St. Petersburg at the most beautiful period, at the most beautiful season, the White Nights. I wish you all success. Thank you.
It's a pleasure and honor to meet you all, and Professor Sankhol, please.
Good morning, dear colleagues. Allow me to welcome the delegates of the International Conference dedicated to the most innovative achievements of endovascular hemostasis in severe traumas and bleedings, the EVTM. These technologies really allow to save severely wounded patients with mass blood loss, starting from pre-hospital stage. And we hope that very soon the endovascular aortic occlusion will be used by all trauma systems in our country as well. Dear foreign guests, outstanding experts in the area of endovascular hemostasis in severe traumas and bleedings, welcome to St. Petersburg, one of the most beautiful cities of our planet. And we are very grateful to you for this possibility and opportunity to learn from you about the cutting-edge technologies of treating the most severe patients. I wish you fruitful work. Thank you. Dear colleagues, next presentation will be delivered by academician Ali Khan, the first presentation of our conference. He is on his way from the airport, though, so we'll make a transfer Yes,
Да, Чак Фокс, один из очень уважаемых, известных
Charles Fox, the most outstanding specialist on endovascular surgery from Denver, Colorado, one of those people who started using endovascular surgery in military settings, first stentings and embolizations in military settings were conducted by Charles.
Give a talk today on innovations in endovascular management for surgical bleeding. Well, how do we decide when we use endovascular capabilities to manage trauma patients? I think it goes back to really understanding what your capability is within your center, knowing that you have the adequate resources to manage a trauma patient collaboratively as a team. And if you find yourself saying that the situation is hard or the operation is not easier, using catheters and wires and sheaths, and you become frustrated, you have to anticipate that there will be a number of distractions which will make the situation much more challenging. For the first time in the global war on terror, the US military deployed vascular surgeons to the battlefield. And as we know, managing ruptured aneurysms, that the mortality really hadn't changed with open surgical interventions until the advent of endovascular aneurysm repair. This is a patient of mine who had an injured subclavian artery, and you can see the obvious potential for bleeding, the challenges with a difficult exposure, and the effects on the physiologic status of the patient with open surgical approaches. These are very difficult recoveries when you perform a sternotomy or a thoracotomy to control truncal hemorrhage. And it's much easier if you have the catheters and wires and sheaths that you need to obtain proximal vascular control. This is an example of an innominate artery injury in a blunt trauma patient who required sternotomy and division of the clavicle to reach the innominate vessel. Now, these carotid bifurcation injuries are not that challenging in terms of exposure, but let me illustrate two very different patients. Which carotid artery would you prefer to cut down on and control a pseudoaneurysm? And this picture displays two very different patients, the one with a penetrating injury versus the one with a blunt cervical carotid injury. Two very different patients, two very different challenges with respect to access. Well, there are a number of devices now, and we'll talk a lot about this in this symposium, the use of balloons for occluding vessels, use of covered stent grafts. I'll show you a few examples of coil embolization and covered stents to deal with occult vascular injuries, stent grafts, and intravascular ultrasound. Early in our experience in the military, we would use peel packs pasted to the wall of a mobile surgical hospital with the basic elements, which would be access wires, access sheaths, and I recommend color coding the blue, black, and green wires, or the glide wire, the Rosen wire, and your Lunderquist wires, so that circulating nurses and other operating room personnel can quickly pull the materials that one needs to quickly deal with a subclavian artery or a femoral artery that's bleeding and get quick access and control of that. This is an example of a soldier who had suffered a blast injury to the lower extremity. Many times, these occult vascular injuries are picked up simply by good physical examination. And this is one such case where you see the rapid venous filling on basic diagnostic angiography. And the posterior tibial artery was giving rise to a nearby vein. And these arteriovenous fistulas, when discovered late, can be very difficult to expose and treat. The blood loss can be significant at times, and while the access to a posterior tibial is not particularly challenging, These are easy cases to treat with coil embolization. And this is our completion study after placing a coil across that communicating branch. And we discovered that the anterior tibial circulation and the perineal was an adequate amount of runoff to safely coil that posterior tibial artery, eradicate the venous inflow, and get a good result. Now, subclavian arteries can be feared injuries, and this is a 20-year-old male who suffered a penetrating injury to the chest, a fracture of the clavicle, and this patient had a chest tube placed for pneumothorax. The junior resident noted there was a bruit over the left subclavicular region 12 days after the original injury. And the blue arrow represents the early venous filling from this subclavian artery pseudoaneurysm with an arteriovenous fistula. This is a great way to get involved in endovascular interventions, just simply performing diagnostic studies. And a wire easily crossed the lesion, and we positioned a 10-millimeter Viabond stent. This otherwise would have been a challenging dissection 12 days after the original injury, coupled with probably an insignificant amount of blood loss in inexperienced hands. And this is a great way for all of us to get involved in cases that can result in challenging exposures at times. And this is our completion study after placing a covered stent graft. A 23-year-old male had a gunshot wound through the left upper arm. It was treated with debridement and external fixation, but 3 months later, the patient had a painful mass in the left axilla. This is an example of that wound. And incidentally, we did not see infections of intraluminally placed covered stent grafts in the upper extremity or chest. And with positioning of a wire across the lesion, was able to deploy an 8-millimeter covered Viabond stent in this region. This is the pseudoaneurysm that you see on a digital subtraction angiogram, which can be done easily with portable fluoroscopy units, and then the completion. There are times when the antegrade access is challenging, and this was a retrograde approach to an occluded subclavian artery. You can see the bullet fragment in the region of the right axilla. And with cutting down on the brachial artery and passing a wire retrograde, we're able to use a body floss technique and obtain access to the lesion using standard wires, standard covered stents, and a 10 French sheath. And this is an example of 2 fluency stents that we used at the time to cover that lesion and get a good result with minimal blood loss. Now, balloon occlusion is important. We're using hybrid techniques, and this is an example of a pseudoaneurysm that occurred very late following fragmentation injury, injuring the profunda femoral artery, which, as you know, with open surgical techniques can be a deep exposure, and these leathery cavities can be difficult to get into to fix any associated venous fistula. We use the balloon to control, using an up and over technique, the inflow to the femoral artery, and then with relative ease, cut down on the vessel, identified the fragments, and elected to repair the profunda femoral using a saphenous vein interposition graft. This is an Iraqi captain who came to me in the Baghdad hospital in 2006. He had a pulsatile mass in the supraclavicular fossa of the left chest. My concern was that this was probably a pseudoaneurysm of the subclavian artery, could be a very difficult dissection. So we elected to perform an angiogram and discover that it actually wasn't the subclavian artery, but just a branch of the thyrocervical trunk. And by getting in it, could place some tornado coils and occlude that, and then just simply remove the painful mass, which was of interest to the patient. So in summary, occult injuries after fragmentation are very common. They require an astute physical examination. They usually present with pain, pulsatile masses, and bruits. The blood loss can be significant when dealing with older injuries that present late. And this is an example of some endovascular techniques that have advanced the management, provided they are done in the right place, at the right patient, at the right time. Thank you very much for your attention.
Thank you, Dr. Fox, very much.
Thank you, Dr.
If anyone have comments or questions, just feel free. The idea is to have an open discussion. As you all understand, we have a simultaneous translation, so we can do it in Russian or in English. So we would love it to hear what people think. I would just have to ask you maybe a provocative question. You have so many endovascular tools, you're an endovascular expert. When would you choose to do open surgery? And when would you say, I don't want these tools, I want the good old surgery? Do you have any tips, especially in trauma?
Thanks, Tal. I think that's a great question. Simply, I would say I would do what's easiest. And what is easiest in your hospital might be different than what's easiest in my hospital. I think if the surgical access is challenging, the potential for a big physiologic insult with an open operation is not in the patient's best interest, and you have the proper inventory to deal with your problem with endovascular tools, then it makes sense to do that. In some settings, in community hospitals where people are unfamiliar with the materials that you need, there can be a lot of frustrations and a lot of distractions just trying to organize the team around an endovascular approach. If you want to implement these types of innovations in your system, I would recommend just starting with diagnostic therapies and getting people familiar with portable fluoroscopy units, floating tables, portable power injectors, and just doing simple things, diagnostic things. As you start to gain some skills and experience, then you can buy a limited amount of inventory and start into coil embolization, deployment of IVC filters, and then maybe working up to some stent grafts.
Well, thank you. We have one question from the audience, please.
Сейчас меня слышно? Спасибо за прекрасные примеры, которые...
Thank you for the great examples. Well, thank you so much for the great examples, because you have managed to illustrate what can we do through PCI approach. And it was of special interest to see the graft stent implants when you are talking about deep arteries, when the approach itself is quite challenging. But from practice, we know that the implanting of also stents, it requires disaggregant therapy, despite the arteries being quite large. Plus, these kind of patients have a combination of traumas. They have soft tissue traumas as well, and many concomitant conditions that are not quite compatible with disaggregant therapy. So should we really administer disaggregant therapy, antiplatelet therapy, and if yes, when and how and for what duration? Thank you.
Thanks for your question. Certainly a controversial area, because it, again, with dealing with large vessels, going to require a team effort to deploy endovascular technologies. I think the AAST trials looking at thoracic aortic injury clearly demonstrated survival benefit to patients who were treated with TEVAR. And while those patients do have concomitant soft tissue injuries, fractures, and other associated injuries that convey a high mortality, the aortic injury related mortality has been dramatically improved with the advent of endovascular devices. So too with ruptured aneurysms, the mortality with treating a rupture with EVAR is significantly reduced, but we've seen demonstrated by multiple large centers that it does require a team effort to mobilize a patient with a ruptured aneurysm to the operating room. Harborview in Seattle has a great experience with dealing with both of these injury patterns and has demonstrated significant strides in the use of these endovascular technologies. So I would still say that if there are anatomies that are favorable to endovascular devices, it's worth an attempt.
Chuck, just a brief short question, practical question. We have a patient in our clinic now with a stent graft placed in the superficial femoral artery for severe open femur fracture. And we put a stent graft, and the patient had a severe TBI with contusions in the brain. So what could you recommend us, whether we need to administer antiplatelet therapy, anticoagulation, what would you do in your clinic?
Well, I think, peripheral stents placed in the extremities don't require systemic anticoagulation. I think regional heparin is useful at the time of the graft deployment, while there are occluding sheaths in the vessels. But subsequently, once flow is reestablished, I think an 81 milligram aspirin tablet is adequate. In the early perioperative period, if the patient has a traumatic brain injury, I think it's an individualized decision with the trauma team and the neurosurgical teams. But I think, antiplatelet is more important than anticoagulation in these settings.
Well, thank you very much. So we have no time for any more questions. Thank you. Thank you, Chuck. Следующий доклад от...
And our next speaker is academician Alekian. He will talk about the endovascular surgery in Russia today. Esteemed Presidium, dear colleagues, it's a great honor and pleasure for me to be here at this very important meeting. This is the first in its kind conference conducted in the PCI treatment of traumas, hemorrhages, and surgery. This is a very interesting event. When I heard about it for the first time, I said I must attend because I'm highly interested to be in an event of this kind. So thank you so much to the steering committee, to the Military Medical Academy for the opportunity to participate. Let me briefly tell you about the current state of endovascular surgery in Russia. I'll tell you what has happened in our country, what we came to, and what should we anticipate. Here you can see the data over the last 10 years. You can see how we managed to increase the number of PCI centers in our country from 157 centers to 353 centers. They all function in our country. The number of ORs in cath labs also grew significantly, and it's important to say that we have the growing number of specialists, PCI operators. We had 907 specialists, and years later, we are almost 2,000 in number. You can see here the number of all patients that went through cath labs. 741,000 patients have been treated in 2018. This is 3.5 times higher than 10 years ago. On this slide, you see the same data, but per 1 million of population. And if we had 451 patients per 1 million of population. In 2018, we had over 5,000 patients. A crucial issue for us is to see what is the working load of our PCI doctors. This is the data we publish every year. This is 2005. Back then, every doctor was doing 117 PCI interventions per year. It was a very, very low parameter. At the moment, a statistical PCI operator is doing 380 procedures per year. I think it's really a small figure again. I think per day, 2-3 patients at least should be examined and operated by a PCI operator. By this slide, I want to illustrate that we have a huge potential. Given that we have 2,000 PCI operators, we have great opportunities to increase their working load without increasing the headcount. You can see here the number of patients that were selectively qualified for coronography. Almost 500,000 of patients went there. Over the last year, we increased this figure by 245,000. In the previous year, we had only 145,000 of these kind of patients. Per 1 million of population, we have 1,300 patients who are qualified for selective coronography. A very important thing is approach in PCI. Huge progress globally and in our country. Transradial approach is amazing. In 2011 we did only 17 procedures, we've achieved 80%. Now we hope that this figure in the coming 2-3 years will near 95%. This is the mortality dynamics when doing coronography in Russia. 500,000 cases, 76 mortalities. Mortality is 0.01%. These are the percentages quite acceptable for this procedure globally. This is the number of PCI interventions done in our country in total. And please note that almost 300,000 PCI interventions were done in 2018. It's 4.5 times higher than the same parameter of 2009. PCI, 41,000 done in 2009, and 10 years later we have 221 PCI interventions. It's more than a 5-fold growth. The breakdown per 1 million of population shows us that we had 27 PCIs per 1 million, and now we have 1,500 coronary stents per 1 million of population. And again, let me talk about the approach. 22% of transradial approach in 2011 and 84% in 2018. The number of stents, this is very important. Last year we implanted over 300,000 stents. And as you may see, unfortunately, the challenge is that only 57% or 58% of the patients had drug-eluted stents implanted, and 41% are bare metal stents. This is really a big challenge. We several times discussed it with the Prime Minister, Vice Prime Minister. There are solutions, and on the website of the Ministry of Healthcare, you can even see the guidelines that we developed and the governmental decree saying that at least 85% of stents should be DES in our country. Unfortunately, the problems are of administrative nature, but I hope we'll tackle this challenge this year. We need to use the drug-eluted stents in 99.9% of cases, indeed. You can see the severe group of patients with the failures in the left coronary artery, and Syntax study and many other studies show that we can work with the patients with LCA failures. And have a look, please, in 2000 and 18, we had 7,600 patients with LCA failures. This is the dynamics and statistics for the patients with acute coronary syndrome. They are included in the national healthcare problem. We actively work with them. 160,000 patients with acute coronary syndrome were admitted to our centers. Compared with 2018, the number of these interventions grew 15 times and above, and we are very successful in doing so. Mortality rate in PCI, it was within 1%, but as soon as we started operating on the patients with acute coronary syndrome, we already have 221,000 patients and 1.6% of mortality rate, because the overwhelming majority of patients are MI patients. What is going on with cardiac surgery and endovascular surgery? You can see here the data for 2017, because the cardiac surgeons haven't yet presented the data for 2018. In blue, you can see the CABG surgeries, 36,000 surgeries per year. Red curve shows the number of PCI interventions growing, and in 2017, 85% of PCI interventions were for stenting of coronary arteries, and only 15% of interventions were CABGs. These are the surgeries on children with congenital heart disease. We had 3,000 surgeries in 2009, and then we doubled this number by 2018. We do PCI on congenital heart disease pediatric patients. The problem of the transcatheter valve prosthesis. Alan Gribier, this great person, in 2002 for the first time developed this valve, and for the first time he operated on a 91-year-old patient, and he implanted this valve through femoral approach, and it was a revolution indeed. And today we do these surgeries. The first surgery for the aortic valve prosthesis was done in our country in 2009. Last year, we had 941 aortic valve replacements. Yes, it's not much, but this year we're planning to have 1,300 surgeries of this kind. They are expensive. Each quote is 500,000 ruble worth. What's happening globally? Let me present the data for the US. The transcatheter prosthesis, the TAVI technique, was started there in 2012. They had 4,600 valves implanted. 5 years later, they had 50,000 PCI interventions and TAVI. And SAVR, the open surgery technique for the aortic valve replacement, is going down in the US. 2/3 of all the endovascular valves were replaced through PCI approach, and open surgeries are going down. We see the similar picture in Germany. 65% of interventions in Germany are TAVI. The PCI approach is exercised. As for the SAVR, the open surgery, it's going down. This is the data for Russia. We don't have the surgery for data for SAVR, but you can see that TAVI is going up, open surgery technique is going down. We hope that sometimes in the future these 2 points will cross, and then they will continue developing in this way. It's very important to say that TAVI was designed for high-risk patients who, for different reasons, couldn't be qualified for open surgery. However, the most recent data at the recent meeting of the American Cardiology Society published the research by Neil Gurman and co-authors, and they showed that the patients with low risk, the patients who were candidates for open surgery, cardiac surgery, but they were done PCI on hemorrhages, on mortality rehospitalization. In 1 year, these patients have a better outcome than the patients who had suffered. Professor Braunwald, he's one of the pillars of global cardiology. He had a meeting, he had a presentation in our center, and he said that we are living in historical times. We have ultimately low risk, and we'll keep talking about this meeting more and more. The technology is already there, and we can do these surgeries indeed today.
Question from the panel or the audience? I would like just to ask you, thank you for your talk. You show how endovascular methods are going up in everything, and it would be very interesting to follow also trauma and bleeders and others also. Anyway, it can be done in Sweden, in Russia, to find and to see how these curves are changing. Can you see the trends also in other aspects like bleeding and others in Russia?
You know, in my country, we performed 40,000 peripheral intervention. This is the intervention aorta and peripheral artery. In this material, we included the bleeding, we included using the cover stent and many technologies for the embolization, for the bleeding in the abdominal surgery, after trauma. We have this experience, but now this meeting is very important for us because now we can start together. It's the same team, you know, the vascular specialist in my country. We can together start.
Баграт Ильич, позвольте тоже задать.
Academician Alekian, let me ask you another question. The PCI technologies are coming to different areas in hemorrhages, in traumas, etc. So please tell me, is there any even theoretical possibility that the basic endovascular interventions would be done by the non-PCI operators? By non-PCI operators, you know, when in 2009 we created this profession, we wrote down in the documents that PCI, endovascular surgery, is welcoming cardiac surgeons, cardiologists, neurologists, gynecologists. I didn't show you, we had 8,000 interventions in oncologies. We had 5,000 PCI interventions in gynecological diseases. So we created these opportunities. Any specialist today can be certified and start doing these procedures. This problem has been solved. We just need to master the technique. Can a person without certificate, for example, a general surgeon, can he perform a basic PCI procedure, for example, the balloon occlusion of aorta without any preparation? Well, just like a PCI operator cannot do an abdominal surgery, likewise an abdominal surgeon cannot do PCI, but you can easily master that technique. And you know, we have teams. I showed you 367 centers. Each has a PCI team. In every constituent entity of the Russian Federation, we have several centers. We don't have a problem here. You just can make a phone call, and our PCI operator can go to a community hospital and help with the hemorrhages.
A question.
Мы сегодня обсуждаем, да.
Question to you, Bagrat, as the main specialist of the MH. We're discussing that organizationally in the near future, very many patients will be treated endovascularly. I mean, patients with trauma. But in terms of coronary syndrome, the patients who are admitted with coronary syndrome are referred to X-ray operation room. I understand that the patients with traumas cannot go to the same operation room. How should this be organized? Maybe we should organize hybrid operational rooms in such clinics, because I understand the team approach, but the question is where? It's a very serious question. You're the founder of Neura. of endovascular procedures in our country. Together with Dr. Kanduba, you are the leaders. You have created a wonderful school, and we are proud with your experience. Acute coronary syndrome and acute ischemic in a stroke. I didn't manage to tell you, but as of now, last year we carried out 1,800 extractions in acute ischemic stroke, while in the year before last there were only 800. We are lacking angiographic equipment. Yes, but we have to distribute our resources right. But certainly we need additional centers, additional equipment. We have scheduled patients, we have acute patients, and first and foremost, acute and subacute infarction. These patients go first, but then we can expand further. Thank you very much for your presentation. It's a great honor for me to announce Tal Horer, the president of EVTM Society and the Vascular Resuscitation and Trauma Management. He comes from the Swedish Örebro. You're welcome. The floor is yours.
It's a great honor to be here, and first I would like to congratulate the Russian people, the Kirov Medical Academy, Military Academy, Professor Samokholov, the faculty of the Military Institute, and the colleagues here. And I think you guys are doing amazing work, and it's an honor to be here in Russia and be a part of it. Thank you very much. So I would speak about EVTM. EVTM, it's quite a new concept, and I will try to talk about it. I think one of the major issues we speak about is no ego, just good science and cooperation. So I think we want to change a bit how we think. We don't want to compete, we want to do things together. Many years ago, in '96, my dear colleague and mentor, Dr. Thomas Larsson, started with endovascular procedures for aortic treatment, EVAR, and ruptures. And today in Örebro in Sweden and in many other countries, it dominates with endovascular tools to stop bleeding. So today in our institute, we are doing 100% of the cases by EVAR. This is possible to do if you have different methods that can help you. I will not name some of them, the access method, chimneys, different graft, etc. And of course, the aortic balloon. And it's about high interest in this area of endovascular and hybrid surgery, and high interest in resuscitation and hemodynamic instability. So these are some examples how it can look like when you're doing endovascular procedures, of course, percutaneously with the use of balloons, stent graft, etc. And we try to speak about this in this review article from 2018. And this is a change during years, quite a lot of years of development that brought this together with great cooperation with other people. So we're talking about the bleeding patient. Vascular emergencies like rupture aneurysm, trauma, of course, iatrogenic, postpartum bleeding, gastrointestinal, spontaneous, Coumadin bleeding. So it's quite a lot of people, and if I might say, the new era of NUAC, the new anticoagulator bleeding, which is on the rise. These are some examples of profound artery bleeding and endovascular treatment of this, or hybrid, thoracic trauma bleeding, and some others, and some examples here. These are all bleeders that you can use different methods. I will speak about it. But we also speak about the unstable or potentially unstable patient. Different medical emergencies, hemodynamic instability, cardiogenic shock, maybe bridge to ECMO, some treatments, and ECMO as a treatment possibility, and other CPR conditions. And this is what we call the EVTM concept. So this is a concept that gathers things that are here, that we've been using in many years, in a collaborative form, together, different specialties. one of the major important thing about EVTM is effective teamwork. So it doesn't matter if Chuck here, Dr. Fox, I'm sorry, is a cardiologist, maybe we can work together and do things together in a teamwork. Early vascular access. I'm a strong believer that every potentially or unstable patient should have a femoral access, both arterial and venous. This is my personal opinion. Permissive hypotension, CT angiography. CT should be done as much as possible with its limitation in a very short protocol, short time, and a dedicated protocol. And the use of angio table or sliding table to operate on as a tool. The use of Riboa aortic balloon occlusion if needed. And use different methods, endo and hybrid methods, to help you, for example, not to open a new cavity and do minimally invasive, if possible, for the correct patient. But EVTM, nothing of this replaces open surgery. It's a complementary to open surgery. There are some examples in the literature, and there are many articles describing these methods about endo and hybrid methods that can be used. These are some examples for thoracic stents in trauma, non-trauma, other bleeders, use of balloons, new tools you can use. Endovascular tools, this is endograft in trauma, balloon in, I think it's a rupture there, subclavia, as Dr. Fox described, and other cases. This is how it can look when you insert a thoracic stent graft. And if you've done a TVAR on a trauma, on a bleeder from the thoracic stent, you know how much time you can win. So the procedure time of putting a stent graft here and stopping the bleeding, it's minutes. It's the whole things around, the access, the getting the patient, but the treatment is very effective, like in this example. Or this example of iatrogenic catheter in the subclavia with a heparinized patient that you just don't want to take away the catheter. You can prevent problems. This is with a balloon expanded stent graft, but you can use different things. Or different embolizations in trauma and non-trauma, and we all know how effective this can be, like in these examples. And of course, the Riboa, the aortic balloon, which is a very hot issue in trauma management. It's just a tool in the EVTM, and we will speak about it later on. Most importantly, in the EVTM concept, you should speak about the vascular access. And I think we forgot in the last year how important these accesses are, not only for Riboa, but other tools, blood gas analysis, taking examples, giving blood, etc., etc. And this can be very challenging, depends on your patient, of course. EVTM and the use of Riboa is increasing. Many countries, we have a great cooperation with. Some of the people are here, and I think we saw an example how we can collaborate and get things moving in many countries in a beautiful way. This is an example of an EVTM flow, might be suggested. This is a jumper. He came in. The first thing he gets is a femoral access, and then he goes on. The access is seen on my left side here, and then he goes on to the semi-hybrid suite. He is placed on the angio table. He has the introducer. The patient had 90 systolic pressure, so of course he did not receive any balloon occlusion. Pelvic packing, angiography control of the bleeding, and then that's it without moving the patients. But then maybe in the future we will see, and we will hear from Dr. Kinoshita about the hybrid ER. And we hope maybe in our center also in the near future you can use this kind of technology on the patient's arrival on the same place. It will be very exciting to hear it later on today. Personally, I see EVTM as a paradigm shift in trauma care, but not only trauma. It's now in several textbooks and manuals, like the DSTC manual, the top stent that Dr. Reva and the team did amazing work and translated into Russian, and the JVTM that is coming 4 times a year. Reboa itself, it's part of the EVTM concept, and in our hospital we have 4 stations that you have this set that you can use it in surgery, in the angio lab, in the ER, in the ICU. These are some examples how this can be used in different situations, trauma and non-trauma, in difficult patient, gastrointestinal bleeding, etc. And I think there is a huge winning effect of having these methods available at hand. Part of the EVTM concept is also to avoid complications. And doing complication, and myself doing these complications, you learn very fast that you have to think and you have to avoid them. And these are some examples. So whatever we are doing, these are invasive procedures, and you have to avoid also the complication, and at times you have to repair these complications. Shortly, this is an example how we use it in trauma. These are 2 cases coming in the same time, one with a CPR ongoing, a massive gunshot both. One is stable, one is CPR, including the whole kit with Reboa, massive transfusion, and subclavian laparotomy that was negative, subclavian extravasation, stent graft, embolectomy of the leg, etc., and both are alive. Just to say that to mention this example can be used in extreme cases, and this is a young, very young patient that was done recently, and he came with it's a blunt trauma, traffic accident, and he came to us with the ongoing CPR, 15 minutes, total collapse, blunt trauma. And we use this technique, hybrid open surgery and endovascular in the form of Reboa, 7 minutes. And luckily, the patient not only survived, he is at home and feeling quite well with the great work of the team and great efforts from everyone. The EVTM concept is a collaborative form. We're trying to make something in a different way, not something that we do, it's something to share. It's the website, it's the peer-reviewed journal, symposium, as done here by our great Russian friends, workshops in different forms, research, and there are several research areas ongoing, different society activities, and we want to expand. There is the EVTM application, as you saw, top stent, and there is much more to do. And we want to do it more as, again, as a paradigm shift in bleeding and resuscitation management, and I think there is huge work to do there, huge potential of collaboration, and I think we can find better ways to use Reboa, endovascular methods, hybrid methods, and get things done in a better way, in a scientific way, with collaboration and multidisciplinary way. Thank you very much. It's a great honor to be here, and I thank our colleagues from all over the world and our people from Russia and from St. Petersburg for arranging this. Thank you.
Thank you. Спасибо, Tal.
Thank you, Tal. Are there any questions from the floor?
2 questions, Tal. Thank you for the presentation. And I maybe ask you quite the same question as to academician Alikan about who is allowed to perform basic endovascular procedures in Sweden. So you were a vascular and endovascular surgeon, and of course you do. What about emergency physicians? What about general surgeons, trauma surgeons? Are they allowed to perform any kind of procedures, and how you train them to make it possible?
Thank you. It's a great comment and question. To be honest, I don't give a damn who would do it. I don't care. It doesn't matter. It can be a great cardiologist that can do a procedure and puncture better than me. It doesn't matter. What I think matters is a dedicated people that want to learn. So in our institute, the vascular surgeons, some of the anesthesiologists are now getting very much involved. So, and the surgeon will be, and we don't know yet, but it should be people interested can learn. And if you learn and practice, then you can do most of the basic things, in my view anyway.
So if people are interested, does it mean that they can do it by law?
Again?
So does it mean that people who are interested, who are keen on doing endovascular procedures, they can do it by law?
Yeah, I don't know about the law in Sweden, how I would say it, but you don't have a certification at this stage for these kind of procedures. In general, vascular surgeon, endovascular IR people, but if we're talking about RIBOA, there is no regulation about it, as I know.
So you can do vascular cannulation and RIBOA without a specific certificate?
Yeah, you will be checked by the by the Ministry of Health later on, probably. If you have to be a specialist. But I don't know about emergency. I can't speak about the law itself.
Okay. Any какие-то вопросы из зала? Yeah, please.
Any questions more? Welcome.
Great to be here. I maybe can help you here because I do the reviews that we get back from the complications for the Ministry of Health, and it is no problem in the Nordic countries to do the procedure. You end up in problems if you do complications that you don't care together with the people who can do them. So in these cases, when the patients come in as emergencies, whomever puts in the sheath and the RIBOA and tries to save a life is not prosecuted. But if you do an elective procedure in a way that you're not capable of doing, and then you later on may be prosecuted for that because you didn't consult the more knowledgeable person. So anybody is allowed to do it, but of course you should know what to do. Tal, I have a question to you. We encounter more and more patients that would not be saved otherwise, and also we encounter very young patients having in stents, like Charles showed, a 20-year-old guy with a Viaban in the subclavian artery, which is quite likely to occlude actually in the long term. Maybe it's not of very importance here.
Can you speak up a bit?
Sorry, maybe it's not of importance here in the subclavian region, the arm, maybe later on saved in other ways, or not, no needing any procedure at all. But do we need to follow these patients, and who should? And the other end, how do you do the ethical discussion that this patient actually should not be treated? I encountered this 2 days ago with a dementic lady with a bad bleeding, and we had on-call discussions on whether to do a simple endovascular procedure or not, and we actually decided not to do, and she died later on.
Just one comment, thank you, about young patient. I think it's a huge problem. And I spoke, by the way, with Dr. Fox about this child because he has also an aortic injury that we didn't know before we used the RIBOA, and it went well. But we are very careful, as you say, very careful about them. And it's a huge concern to use this. I agree with you about endovascular prosthesis in young patients. Maybe Dr. Fox Chuck, if you can comment on this. And I agree about the training, and I agree about this, that we have to be very careful who is doing the procedures also.
Well, I think it's an important area of evolution with endovascular management of things, because as a vascular surgeon, we perform surveillance of the extremities after the insertion of the sheath. And what we want to do is get our hands around being the leader of those innovative technologies and making sure that our emergency physicians and our general surgeons and other people who are putting sheaths in are actually surveying for complications. So I think it's real important that in these types of meetings that we present our complications and we show our colleagues how we can do better. I think you pointed out the need to do a good pulse exam and have an ankle brachial index and really know how that patient did after the insertion of a large bore sheath.
Спасибо. Есть ли еще вопросы? Yeah, please.
Any other questions, please?
I'm Dr. Xu from the Taiwan Trauma Association. Wonderful, your wonderful speech. And I have a question for the Zone 1 RIBOA. and the ED thoracotomy, which one you suggest for the patient, trauma patient, more efficient and more useful?
You mean if zone 1 is...
Zone 1 and the ED thoracotomy.
Yeah. It depends what... I'm sorry, we can't hear the microphone so well here. If you're speaking about Riboa and zone 1, the majority of the patients that we get in trauma in our area, you don't know what's the injury. And they are so bad that you use it in zone 1. But the ones that we know it's a pelvis, then of course we try to minimize and use it in zone 3. But also in the registries, the majority are zone 1, which is probably more effective but more dangerous.
Спасибо большое. Thank you very much, Tal.
Thank you very much. Let's go on.
Here is Adenauer Goes Jr. from Brazil. Из Бразилии, это амазонка, Белем.
Mr. Adenauer Goes Jr., vascular surgeon and trauma surgeon, trauma and bleeding. I choose open.
Meeting for the invitation, especially to Victor Riva. First of all, I need to say that I have nothing against endovascular surgery, especially after seeing Fox and Tal Horner's presentation, but my mission is to explain why we choose to do it open at my center. Okay, but before getting to the Amazon experience part about vascular trauma, I will go very fast during the literature review because I want to spend some time with you showing some cases. But literature says endovascular emerged as especially to solve problems of difficult accesses, like thoracic aorta, subclavian, and high internal carotid injuries. Of course, as the time is passing, it has been more and more used, especially for blunt injuries, but also for penetrating injuries, but especially for blunt. And if you search for endovascular and trauma at PubMed, most of papers are about case reports and case series. And after the acute phase, like for example for arteriovenous fistula. Most authors agree that endovascular gives comparable results, but not better, and follow-up is still short. Now, before getting to surgery, a little of geography review. Victor asked me to talk about Amazon experience. Well, Amazon, actually, there are 9 countries in the Amazon, but 60% of this huge area is in Brazil. In Brazil, we have 9 states. I come from Pará state. We are twice the size of France, and at my state, we have only 43 vascular surgeons, and only 1 is on duty 24/7. So it's very difficult to work. This is Belém, the capital of my state. We have about 2 million inhabitants. And Amazon is different from everything. You need to have air rescue, you need to have river rescue. And in my region, we have specific problems. For example, private hospitals and public hospitals are very different. I did these 2 cases. The case is similar, a foreign body, guide wire after central line insertion. At the private hospital, we get a snare in and take the foreign body out. At the public hospital, we need to take the clavicle out and then take the foreign body out. But we need to solve the problem. This is our trauma hospital, specifically for trauma. And from March 2013 to March 2017, we have operated, our team have operated 430 traumatic vascular surgeries, and we do it open, almost everything, but why? First reason, we don't have endovascular at this public hospital. We have endovascular at the private hospitals, but not at this hospital. This is our reality. Of course, there are cases that endo would be the ideal solution, and we try to transfer these patients. What cases do we treat? Almost 52% are gunshot wounds. But remember, we received these cases from a very big area. There is the only hospital with vascular surgery on duty. 36% are cutting wounds, we have falls. Almost 90% are for penetrating cases, and almost 90% also are for extremity, peripheral cases. We did some research at our own hospital. We managed to decrease from 26% to 12% the rate of amputation. And also we find out that if the patient has one single compressible artery injury, for example, the superficial artery, he has about 7% of chance of death. But if he has simultaneous arterial injuries to the neck and the thorax, this chance rises to up 72% of death. So firearm projectile wounds account for almost 52%. In a case like this, a 9-year-old boy with a penetrating, transfixating abdominal wound with many associated non-vascular injuries and injuries to the vena cava and to the superior mesenteric vein. I don't think there is an endovascular solution for that. You need to do damage control, or a case like this, a 13-year-old boy in hypovolemic shock 10 hours after sustaining trauma to the popliteal artery and vein. There is no endovascular for that also. If you have high internal carotid injuries, endovascular could be a solution. But if you don't have it, how do we do it? You can do a transposition from the external to the internal carotid artery. We have 36% of cutting wounds, like this one, for example, at the origin of the aorta at the left ventricle. The patient had how to say that? His heart stopped beating, and we need to do compressions and compressing and cross-clamping aorta. There is no way to do it by endovascular. This shows a subclavian injury after the acute phase. Okay, endo would be a good solution for this case, but if you don't have it, keep calm and call a vascular surgeon. We take the clavicle out and then repair the artery. And the important is to get it fixed. This case, I'm having trouble here. Okay, but this was a vena cava injury that was operated in a far distant area, and they didn't tie it very well. The patient was bleeding from the inferior vena cava for 2 days and arrived at our facility in deep shock. And we operated, and here you can see the vena cava ligated. I don't think it's also an endovascular solution for this. This case is a more recent case. The patient, as you can see, was in deep shock. He was stabbed in the left flank, and we need to do damage control surgery. He had injuries to the inferior mesenteric artery. We ligated. The aorta was sutured, and the left ureter was sterilized. Would endo be better? I don't think so. Motorcycle injuries are a very big problem in my area. This was a female patient who had bilateral knee dislocation and bilateral popliteal injury, and we spent all day doing the revascularization. This other case of traffic injury was a bike versus bike collision with direct impact to the groin. 8 hours after the trauma, the patient was also in shock. I'd like to have endo to do the proximal control, but I don't have it at my facility, so We did extraperitoneal access, and as you can see in the middle photo, the common femoral artery was completely transected. And this was an interesting case. A man who has arrived with right inferior limb, the left inferior limb was traumatically amputated, and he had injury to the left subclavian artery. We took the popliteal artery from the amputated leg and used it to revascularize the upper limb. And we have also other mechanisms of trauma, like this young patient after attempting of central line. You can see many marks. He evolved with very big hemothorax, and he was in shock. And the open book thoracotomy showed a partially transected subclavian vein that was ligated. I don't think endovascular would be a good option here also. So my conclusion after operating some cases of trauma in the Amazon is that endovascular can be actually very, very good, very great for some cases, but if you don't have it, do what you can, how you can. After all, we are still surgeons, and sometimes a Foley catheter and a Jiggly saw can make a huge difference. So, spasiba, and thanks for this amazing opportunity.
Уважаемые коллеги, есть ли вопросы?
Any questions, dear colleagues? While you are thinking over your questions, can I ask you, Adenauer, a question?
So among your cases presented, so you presented most of the cases which are primarily be treated by open techniques. And do you think some of them would be treated in hybrid maneuver? I think you could, for example, to avoid extensive exposure, you can use some balloon occlusion, not aortic occlusion, but some major artery occlusion temporarily, just to avoid blood loss, just to avoid extensive exposures, and to decrease morbidity.
Of course, if I had the opportunity, for example, this case of a young man after the bicycle crushing, the bike collision, I would do a contralateral femoral approach and put a balloon deflated in the external iliac, for example, the contralateral one, and I would occlude it by endovascular technique, so I would avoid the extraperitoneal approach to the external iliac vessels. Or this case of the subclavian, for example, I have other cases of innominate artery. There are, of course, cases that if I had endovascular, it would be great. But we are not there yet at the public health system in my area.
Just have a short question about blood transfusion. Do you have limited, how is it with the blood, the amount of blood you can give in Belém? Is it a problem or it's
it's hell. So we don't have cell saver. People from the hematologists, they don't read the same journals we read. So when we do self-transfusion, like auto-transfusion, I take the blood from the thorax and reinfuse in the patient, we receive a note from the hospital administration because the blood bank people say that it's forbidden. We can't do that. It's harmful for the patient. And we are trying to explain that they need to start reading the trauma journal and not the hematology journal. But we will go get there.
Thank you. Number one.
Добрый день.
Good afternoon. Good afternoon, great presentation. You have a huge state and only 3 vascular surgeons, and you have these kind of patients. They are delivered to the nearest hospitals, as I understand. Who is doing the vascular part? Who is treating your patients?
You have a limited amount of vascular surgeons that you have big region, and the vascular injury patient, they are admitted to the closest facility. So how do you organize this so optimal treatment? Who cares for this patient? General surgeon primarily? To wait until vascular surgeon is coming, or vascular surgeons are primarily operating them?
You saw when I explained that we managed to decrease the amputation rate between a first period and a second period of our experience. Most of that is because between 2011 and 2013, we were on call. We were at home doing other things, and then we go running to the trauma hospital. After 2013, we managed to explain that we need to be there. So we have one vascular surgeon on duty permanently at the hospital 24 hours, but we are only one. When we have complex cases, we need to do this with the general surgeon, or sometimes with the first or second year resident surgeon, general resident surgeon. So it can be very, very difficult to do it.
Number two.
Thank you. Good morning. My name is Jaime Tisnado. I am coming from the United States, from Richmond, Virginia. I practiced there all my life, 50 years. And originally I was born in Peru. And Peru is, according to your map, an Amazonic country. By the way, for those of you who are here, the Amazon River, which is the largest in the world, originates from Peru. I do know many members of the society called Sobrice in Brazil. There are about 500 members, Sobrice meaning the Society of Interventional Radiology and Surgery in Brazil. And I know many of those professors who are very famous in the United States, and all of them are my friends, of course. And I think there is a major problem there if there are 500 people in Brazil, a country of 140 million, maybe?
Maybe.
So you guys have to get together, because most of the doctors of the 500 members of Brice practice in Rio and Sao Paulo. And I think the fact that you only have one surgeon there on call is a disaster. It's a very sad situation. It's as bad as Peru, of course, because in Peru we don't have anybody actually in the mountains. So I would like to ask the Dr. Goss to get together with the members of the society, Sobrice, and get together and see how can you help each other to cover the area of Amazon, because it's a sad situation that from 500 people, most of them are in Brazil, in Rio and Sao Paulo, and nobody in Amazon, being such a big area there. So thank you for your attention.
Can I answer this?
Yes, please.
First, thanks for your comment. As Victor has asked before, in each country, it's different for who can do endovascular procedures. In Brazil, things are very hot nowadays about this topic, because in Brazil, we have Sobrice, that is a society for endovascular and interventional radiology, and you have the Brazilian Society of Vascular and Endovascular Surgery. And many colleagues are at the two societies, but many are not. I think that the solution is what Tao has told me yesterday and again today. We don't need to compete between each other. What matters is to treat the patient. I don't care who will do it as long as it is well done. But that number of 43 specialties I showed at my slide is about vascular surgeons and we not all do endovascular techniques at my region. So we have some interventional radiologists, but I was talking about open surgery, and we are 43 vascular surgeons at my state. We have endovascular from Subrice, not many, maybe 10, but that number was for open surgery, okay? But thanks.
Just one comment. I think there are some basic methods. I don't know if the other agree with me, and we have some trauma surgeons here and highly trained, experienced people here. But there are some basic procedures that I will not be afraid to teach general surgeons and other people. I think it depends on who you have a bit. If you have people that you can trust and do some simple things, you can gain a lot. And I think, for example, in your area, which I know well, it could save, for example, issue of morbidity and blood transfusions, which is a major issue. In Örebro, Sweden, we can give 40 units, 60 units of blood without blinking. I don't think you have the same situation. You don't have the same capacity.
We need to fill a lot of paper. We are operating, doing thoracotomy, laparotomy, and we need blood. And they asked us to fill a lot of papers to get the blood. And we need to explain that we need the blood now and the paper will be filled after. Everything is difficult, but we are trying to solve the problems.
But you have an amazing country. Brazil is amazing.
Thanks.
But this we take later on. Okay, thank you very much for your talk. Great talk. Our next speaker is Dr. Yusuke Matsumoa from Japan. Welcome.
Здравствуйте. Меня зовут Yusuke Matsumura. Thank you, Talon Victor. Thank you, Professor Samokwal of Endocrinology Committee. It is really a great honor to be here. And today, Dr. Goes introduced a great surgical experience, but my role is to introduce the benefit of endovascular. So I'd like to introduce some endovascular option for trauma and bleeding. So these are the endovascular techniques for trauma and bleeding. The balloon occlusion, including rebore, is a feasible proximal control, but it doesn't have the distal control. The stent graft, this may preserve distal perfusion and organ function, but usually this is very expensive and availability is limited. Embolization, and this is the most commonly used technique, but there are some non-embolizable branch. So I'd like to introduce our recent trauma cases. So in the first case, I'd like to focus on the rebore. So 17-year-old male to fall from 11th story of the building. And he collapsed 5 minutes before arrival, and CPR was initiated in the ambulance. The first, we performed a thoracotomy and aortic cross clamp, and he was resuscitated after 8 minutes of CPR. And we found a bilateral pelvic fracture, and we obtained a bilateral arterial and venous access. And the first exam turned positive, so we decided to go to the OR first to do laparotomy. But before moving to the OR, we converted thoracotomy to zone 1 rebore, and we closed the chest and we converted to zone 1 rebore and transported with partial rebore because the patient has some blood pressure. In the OR, we could deflate the balloon within 20 minutes, and liver injury was found, but it was not too severe. Instead, a lateral peritoneal hematoma was expanding rapidly. So we performed perihepatic packing simply and head to the angio suite. So we embolized the bilateral internal iliac artery within 10 minutes, and patient was stabilized. So after the CT scan found the chest wall bleeding due to the thoracotomy. So in the ICU, we closed the chest again, and we transfused a lot of blood. And now he's doing well and transferred for the rehabilitation hospital. So these are the summary of key strategies in rebore practice. The first, thoracotomy plus rebore, the combination. And second is early access. And the third is short occlusion. The first topic is thoracotomy plus rebore. In this case, we performed thoracotomy first. And thoracotomy is absolutely speedy and definite, but you need to make the new chest wound, and it may be the significant problem of the bleeding. In the rebore, regarding the rebore, this is less invasive, but sometimes patient may have the risk of leg ischemia. And there are some papers reporting the benefit of rebore compared to the thoracotomy. But I'd like to suggest the benefit of combination or conversion from thoracotomy to rebore in blunt traumatic cardiac arrest or impending arrest, the most critically ill state. In the current American guideline, thoracotomy is not strongly recommended in pulseless blunt trauma. There is no chance to survive. And in our previous rebore case series, we experienced 30 thoracotomy plus rebore cases. And of these, the 6 patients survived. And interestingly, all of them received CPR before rebore. So it means thoracotomy plus rebore may give a chance even in the pulseless blunt trauma population. Theoretically speaking, the conversion prevents hypothermia, and closing the chest prevents chest wall bleeding. So next, the early access. So Tao introduced the AABCDE concept. So access is always key of the endovascular therapy. So we got double access, and we reported the benefit of early arterial access, analyzing the rebore population. And non-survivors shows a higher ISS and lower pre-occlusion pressure and longer total duration of occlusion and a longer arrival to access time. We performed multiple logistic regression analysis, and it showed arrival to access was significantly associated with the survival. The odds ratio of 0.989 is equal to the 10 minutes delay. A 10 minutes delay is equal to the 10% decrease of the survival. And we set the cutoff value of 21.5 minutes. And early access groups showed significantly better survival outcome. And next, the short occlusion. The partial rebore, in this case, we could deflate 20 minutes. So long duration occlusion must induce the ischemic complication. So survival shows short duration of occlusion, about 30 minutes. But this is not a scientific, but from our experience, 30 minutes should be the longest way at zone 1. In next case, the selective balloon occlusion, this is not the balloon, not the rebore. The 20-year-old male, incidental right thigh stabbing, the big scissors, was stabbed from the back. And this is non-compressible junctional hemorrhage. And here is impending cardiac arrest. But I don't want to open his chest. This is isolated penetrating injury, so I chose zone 3 rebore. And to reduce the ischemic complication, we move to the angial suite and convert to the common femoral artery occlusion. Then we perform the surgery. So such a selective balloon occlusion minimizes the ischemic complication. The next case, I want to focus on the stent graft. So 50-year-old male, iatrogenic right subclavian artery injury. The neurosurgeon may try to make the ventricular peritoneal shunt, and SVP60 hemoglobin was 2.1. And after the procedure, he presented significant right side hemothorax with extravasation. We got the bilateral access, right brachial artery and femoral artery. And right subclavian angiography showed a significant extravasation, but after 15 minutes, we complete the procedure and no bleeding at all. So in the final case, the embolization. I won't explain in detail embolization. This is commonly used, but I want to focus on the combination with balloon occlusion. Again, this is the iatrogenic injury. During the orthopedic surgery, they couldn't control the bleeding from the profound artery. So I first put the common femoral balloon occlusion. Then I can find the profound artery injury and embolization under control the balloon occlusion. So when we think about the comparison between open versus endo, so open surgery is definitive and it can do the proximal and distal control. But the balloon control can make the only proximal control, and it requires angial suite or fluoroscopy. This is a limitation of the endo. And the surgery must be better at the thoracic or peritoneal cavity, cavitary hemorrhage. And of course, it can control the venous hemorrhage. But endovascular, when it comes to the endo, there are some surgically difficult areas, like the subclavian artery or iliac to femoral artery or mediastinum or retroperitoneal area. Probably endovascular therapy can go faster, can reach faster than surgery. So we can choose the simplest way, fastest way from surgical or endovascular therapy, and we can combine with these technology. So of these endovascular techniques for trauma and bleeding, rebord and selective balloon and stent graft and embolization, I want to summarize my topic. The first, rebord is absolutely good RLT control method, but it may be dangerous in the most critically, most life-threatening trauma. We need to open the chest or we need to open the lap. But if we combine with thoracotomy and rebord, we may have the chance in the blunt traumatic cardiac arrest. And early access. This is always key to the success to the endovascular therapy, and we should limit the occlusion duration. And finally, this is the last message. Keep it simple. Choose the best way in each institute, and please combine or convert the aortic balloon occlusion and surgery, balloon occlusion and stent graft, balloon occlusion and embolization. And these combination therapy may be induce a better outcome. Спасибо за внимание.
Yosuke, so какие-то вопросы из аудитории?
Any questions from the floor? And while they are thinking,
time, and you have the biggest probably experience in the world. Could you give us some basic rational things to use in real practice? For example, as I know, so you don't use total occlusion anymore and change to partial. Is it is it true? Or how did you achieve this approach? Why did you decide to do that?
Thank you for the question. Of course, I recommend to use partial occlusion as early as possible, but if the patient's status is too severe, of course we use a total occlusion. But it depends on the amount of transfusion. It depends on the patient hemodynamic. So if the condition permitting, we want to change the partial occlusion from total occlusion as early as possible. But there is no indication of what's the degree of the partial occlusion, what is the safe duration of the partial occlusion. So this is the next topic in this field.
Пожалуйста, академик Аликян.
Коллеги, мы заслушали.
Academician Alikan, we've listened to two very important presentations, an opinion of a surgeon and an opinion of an endovascular surgeon. Very emotional presentation from Brazil. And the surgeon from Brazil showed us that the open surgery resolves everything. Endovascular surgeon from Japan showed us that endovascular surgery also helps a lot. But the reality is somewhere in between. We can't follow only vascular surgeons that they can do everything. The main thing is the interest of the patients. The surgeon may do everything. He can just cut down the patient, practically the whole patient, and then close everything. The question is the time and the trauma. Well, the endovascular surgeon may help the vascular surgeon, and together they will be able to perform the surgery quicker with less trauma, and hence the importance of hybrid surgery. We've started speaking about hybrid, but we forget that today many people manipulate this term hybrid surgery. This term appeared in the US. Mark Galantovich and John Cheaton-Bohaya, two outstanding cardiosurgeons, have introduced this notion of hybrid surgery for the first time at the end of the 20th century. They think that hybrid surgery is needed only in the interest of patient, for example, to operate a small child with congenital heart defect without artificial circulation. And today, hybrid surgery is used when two wonderful experts are working together, cardiosurgeon and endovascular surgeon. And these two super experts have to work together. The question today is whether the surgeon can master endovascular. Certainly he can. Can the endovascular surgeon master the surgery? Maybe not that sure, but you have to understand the results may be different. Hybrid surgery means two outstanding experts. If the Brazilian colleague is a wonderful surgeon, he can do this, but not every general surgeon can perform such an operation. Hence, we have to understand that hybrid surgery is a surgery that means participation of two experts, endovascular and vascular, or endovascular and cardiosurgeons. Everything in the interest of the patients, and then we'll achieve better results. Thank you. One last question from the floor, please. Very informative presentation, but my question is about 30 minutes. Tell me, please, do you think that the fact of longer rebore leads to worse outcome, or the patients who needed to have rebore for more than 30 minutes were more severe, and that's why they had worse outcomes? So the fact of longer occlusion is a worsening factor, or the severity of the trauma? Thank you.
For the question, you're right. I totally agree with you. This is just an observational study, so we cannot conclude any causal relationship. So longer duration kill the patient, or almost dead patient requires longer occlusion. But I think that unnecessary longer occlusion will kill the patient's bowel, and it is usually irreversible. In my experience, the kidney, liver, deed function can be recovered, but once bowel is dead, the patient is going to death. So I'm not sure that 30 minutes is the great magic number, but we need to always think about to limit the duration of occlusion.
Thank you very much. We have to move forward. Unfortunately, so no more questions. And the next speaker is General Munasinghe from Sri Lanka. General is interventional radiology, correct? And yeah, very experienced interventional radiologist from Army, Sri Lanka Army, please. So microphone is yours.
Доброе утро.
Good morning.
Sri Lanka. First of all, let me thank Professor Victor Riva and the organizing committee for giving me this opportunity to talk to you on delayed presentation of vascular injuries in war wounded and its endovascular management. I am going to present you an evaluation of war-related vascular injuries encountered by me as a radiologist in the X-ray department of Military Hospital, Colombo. The injuries in the battle can be gunshot injuries or blast injuries, which can be mortar blast, RPG blast, anti-personnel mine blast, or improvised explosive devices. It can be a single small penetrating wound, or it can be extensive soft tissue damage with or without fractures. It can be loss of limb or limbs. And all these injuries associate with varying degree of vascular injuries. The vascular injuries associated with extensive soft tissue injury, or most of the severe injuries to major vessels, which are obvious clinically, are managed in the battlefield by field medical officers. And permanent repairs are done by vascular surgeons or general surgeons at the initial presentation to Army base hospitals or referral hospitals close to the field. But there is a group of vascular injuries which may not be detected at the initial presentation, because it may be minor injuries to major vessels or major minor injuries to non-major vessels, or which can be marked due to some other reasons like hypolemia, spasms, or compressive bandages, or which are overlooked due to major lesions elsewhere. This is the group of patients or vascular injuries encountered by us as radiologists, and surgeons need our assistance in diagnosis and maybe in the treatment. I am going to present you a group of patients with vascular injuries who escaped diagnosis at their initial presentation and later emerged at different time gaps with different mode of presentation to our department at Army Hospital, Colombo from 1997 to 2012. All of these patients were adult male servicemen aged from 18 to 47. We evaluated the biomechanism, time of presentation, pattern of presentation, anatomic site of injury, and mode of management of the suspected vascular injuries, which are not obvious at the field hospital or base hospital and reported to us from 1997 to 2012. All these suspected vascular injuries, that was 614 we had, were subjected to ultrasound scan with duplex Doppler scan. We were able to group these patients into three major groups. Group A, patient with definitive vascular injuries which could be detected ultrasonically. Number, it was 496, 80.8%. Group B, patients who did not have any evidence of ongoing or active vascular injury, it was 51, it is 9%. And there were 62 patients, that is about 10%, whom we could not detect any active vascular injury. But considering the patient's clinical condition, we could not exclude the vascular injury or active vascular injury with certainty. Group A and C, totally 558 patients, underwent selective angiograms. The lesions which are amenable for therapeutic intervention procedures in our department were carried out in the same setting whenever the necessary hardware were available. Others were performed in subsequent setting after obtaining the necessary hardware. When you see the causative weapon, the majority, that is about 84%, were due to mortar blast injuries. That was common even those days, and now it's common mortar blast injuries. Followed by gunshot injuries, 11.7%, RPG blast, 2.5%, and anti-personnel mine, 1.4%. The pattern of presentation. Two most common pattern of presentation among these patients are pain and swelling and lump, accounting for 26.7% and 22.5% respectively. When you see the type of injury, majority of these patients or injuries were false aneurysm, accounting for 33.7%, followed by complete occlusion of vessels or thrombosis, artery-venous fistula, aneurysm with artery-venous fistula. There were 49 patients, that is 7%, did not have any vascular injuries, and those are the patients from our group C on sonographic evaluation. When you see the time of presentation, majority of these patients presented within first 18 months after injuries. When you see the time of presentation during first year, all the active bleeders and significant number of thrombosed vessels and majority of aneurysms, artery-venous fistula with aneurysms presented within first 3 months. When you see the presentation within first month, all active bleeders and significant number of thrombosed vessels have presented within first 3 and 4 days. When you see the type of angiograms, the majority of injuries were in the limbs, hence femoral and subclavian are the commonest angiograms. When you see the site of injury, this confirms my former statement. When you see the association between the site and type of injury, irrespective of the region, most commonest injury was aneurysm. Thrombosed vessel was the next, in limbs and abdomen, but in head and neck it was artery-venous fistula. There were significant number of artery-venous fistula in the limbs and abdomen, but artery-venous fistula with aneurysm were common in the limbs, particularly in the lower limbs. The mode of intervention. Majority of these patients, that is about 50%, have been treated by minimally invasive radiological intervention, of which major portion was limb injuries. 35% of these patients were treated surgically. Majority of head and neck injuries were treated surgically. When you see the type of intervention, coil embolization was the most common type, accounting for 53.8%. The artery-venous fistulas or aneurysms, sometimes bleeders, were embolized by these coils. You can see in the top part on the left-hand corner, the commercially available coils, but we had problem initially. We didn't have enough number of coils. The demand was high, so we have to improvise our coils using guide dryers. In the bottom part in the left corner, you can see improvised coils using guide dryers. The stenting, 9.3% of patients, 1/3 of the patients underwent stenting for aneurysms, artery-venous fistula, and artery-venous fistula with aneurysms. 9.3% of patients underwent gel form embolization for active bleeders. 3.6% of patients underwent balloon dilatation for occluded vessels or narrowed vessels. As you can see here, The vascular injuries can present within hours, days, months, or years after injury. We have to be vigilant. Look for the vascular injuries even though the external wound may be small. Ultrasound is a good screening tool, but angiogram is gold standard. Majority can be treated by minimally invasive interventions. Spasiba большое.
So, General, thank you for this nice presentation. You have a lot of cases with delayed vascular presentation of these cases. And what about critically unstable patients? Do you think that endovascular techniques can be used in patients admitted late and with signs of critical instability, I mean hemodynamic one?
Yes, always we select the patient with consultation with the surgeons and the anesthetists. And if the patient, if they feel we can do and if we are confident, we take forward. Critical patients, yes, of course we can.
Okay, if no comments, then we move forward. Thank you very much for your talk. And the next speaker is Laura Moore, please. Someone, trauma and vascular surgeon from the United States of America. Microphone is yours.
Good morning, and Victor, I want to thank you again for the invitation to come speak. It's really a privilege to be here, and I'm going to talk to you for the next few minutes about REBOA and why and how you should implement it at your institution. I don't have any financial disclosures for this talk. So we're all here today talking about the endovascular management of the bleeding patient, and we're all very aware of what the problem is. And when we talk about endovascular management, specifically REBOA, we're addressing a very specific type of hemorrhage, and that's non-compressible hemorrhage that occurs below the diaphragm. We know that hemorrhage is the leading cause of death in both civilian and wartime injuries. And this vascular disruption that occurs can rapidly progress to cardiovascular collapse if we don't get adequate hemorrhage control. So REBOA offers us an option to get early temporary occlusion of the aorta to minimize hemorrhage and stabilize the patient until we can get to that definitive hemorrhage control, whether that be in the operating room or the hybrid suite. So why should we do REBOA? Again, I think time is critical in these patients, and REBOA offers us a faster option that could potentially actually be deployed in the pre-hospital environment for earlier control of hemorrhage. So let's talk a little bit about times and why we focus so much on earlier hemorrhage control. So those of us that take care of trauma patients receive them in a variety of ways, but let's just say at time 0 you have an accident or an injury occur. In the United States, the time from the actual accident until EMS arrives on scene, the median time is about 7 minutes. Once the patient is transported from the scene to the emergency room, again, transport times vary depending on where you are and what mode of transportation you have available. But it's 37 to 76 minutes to get from the scene to the actual emergency room. So now you're about 45 minutes to 83 minutes into your resuscitation. Patients are bleeding throughout this entire time before they actually get to the emergency department. Once they get to the ER, if we decide we're going to go to the operating room or the hybrid suite, it takes us about 24 minutes to get from that emergency room into the place where they're going to undergo definitive hemorrhage control. But at this point, the patient's been bleeding from 68 to 107 minutes, which is quite a long time. And then by the time we actually get hemorrhage control, it usually takes us about another hour before we get definitive hemostasis. So now you're looking at 135 to 174 minutes. That's over 2 hours from the time of injury until you get definitive hemorrhage control. Now, obviously, during this time, we're resuscitating the patient. If we have blood and blood products, we're giving those. But that's quite a long time for patients to be bleeding without some sort of hemostasis. So when we look at data, this is from our institution in Houston, at when do patients with truncal hemorrhage die, the median time to death is 99 minutes. So if you do the math and you look at our median time to death of 99 minutes and our median time to hemorrhage control of 135 minutes, you see very quickly that on the average, we're about half an hour to an hour too late in getting definitive hemorrhage control, which is why so many of these patients die before we're able to control their hemorrhage. So I would propose that Reboa can provide an earlier temporary hemorrhage control option for these very critically ill and injured patients. So now, how do you do it? How do you implement Reboa at your institution? And I was very fortunate to be participating in an institution at the Red Duke Trauma Institute in Houston, where I'm from, to implement Reboa in a very large, high-volume Level 1 trauma center in the U.S., and it's really a team effort, and so in the next few minutes I'm just going to share with you some of my thoughts about how you can successfully implement a Reboa program at your hospital if you don't have one already. So some of the key elements, I think one of the first things is you have to identify who the stakeholders are. We've talked a lot this morning about collaboration and teamwork and identifying who the experts are in your hospital and who can help you manage these patients. So it's not just the trauma surgeon. It's the trauma surgeon needs to know how to do the procedure and needs to understand it, but you've also got to engage the other clinicians that are going to be helping you take care of your patients. This requires you to train those individuals. Even if they're not going to do the specific portions of the procedure, they need to understand what's going on, the equipment that's going to be needed, and some of the physiologic changes that you might anticipate seeing. So that involves anesthesia, your emergency department colleagues, your vascular colleagues. If you do not do your own vascular surgery and you have a complication from Reboa, you need to be friends with your vascular surgeon so that they can come and help you out when you run into complications. And then the issue of credentialing, that got brought up a little bit earlier today. What is the credentialing process for your hospital? Can you do a Reboa, or do you have to undergo some sort of specialized training in order to be credentialed, and determining who the people are in your institution that are allowed to actually perform the procedure? And the next part, I think, is you've got to create a guideline. So practice patterns differ throughout various regions of the country and throughout the world, but no matter what you decide to do, you've got to come up with a guideline for what's going to be the institutional standard where you practice medicine. These are just a couple of examples. One is our Reboa guideline that we use in Houston, and the other is a guideline from Japan. So again, creating a guideline, making sure that there's buy-in from all of the key players in the creation of this guideline, and then monitoring the guideline to see if you're compliant with it and how you can improve it based on your experience. And then the next step is really important, and that's making sure you have all of your equipment available. Reboa is a relatively straightforward procedure to perform, but if you don't have all of the key pieces of equipment in one place, you're not going to be successful when you implement it. Remember that when you're doing this, it's not an elective procedure. You're doing this in a patient that's very unstable. There's a lot of things going on with this patient, so knowing where your equipment is, how to access it, and making sure it's all in duplicate in case something falls or doesn't work or drops on the floor, I think is really important. And so once you've assembled your kit, which is really your arterial access, your sheath, and then whatever catheter you're actually using, I think it's important to have that kit replicated and placed in all the places you might potentially be using it. So obviously the emergency room, the operating room, the IR suite, and then we also keep these stocked in our ICU in case we have an ICU patient that we think would benefit from Reboa. And then the final element I think that's really important is training. And this is I think, somewhat controversial topic about how do we train people and who should be trained. And again, I think it depends very much on your skill set and what you feel comfortable doing. We've heard a lot of people talk that are vascular surgeons that have specialized training in vascular, and some of these techniques come easily to those people because it's part of their core knowledge set. But for non-vascular surgeons, you can still learn to safely do Reboa. In fact, I think non-surgeons can learn to safely do Reboa with the proper training. So again, education is important. There's several options out there. The best course, which is run through the American College of Surgeons is an option that we use, and that's how we've trained all of our providers in Houston. You can take it in the U.S. We have visiting courses that can come and train at your institution. But whatever you choose to do as far as training goes, it's important for everybody to be trained and credentialed before you start implementing the program at your institution. And then quality assurance, I think, is really important. Dr. Fox mentioned the importance of talking about our complications and disclosing our complications. We do things to patients in an attempt to help save their lives, but sometimes there are complications that result, and that's okay. We need to talk about them and we need to learn from them, especially early on in your process at your institution. Identify the complications, watch really closely for them to happen, and then talk about them and talk about what steps you can take the next time to prevent those complications from happening on future patients that are going to be in your care. This is a great article I just want to mention. Again, I think anyone starting a REBOA program at your institution needs to become familiar with the literature, the indications, the complications, the pitfalls, and this is a great article that was assembled by several people that are on the podium today, talking about our complications that we've seen and a vast experience of REBOA and reporting those complications and strategies to avoid you repeating the same mistakes that we've made in the past with some of our patients so that we can make this procedure as safe as possible for our patients. So just to take home, I think REBOA can provide an earlier option for temporary hemorrhage control. It is not definitive hemostasis, but it is earlier temporary control, and I think that that could be of great benefit to our patients. If you're going to start this at your institution, you've got to identify an institutional champion that can ensure that all of these steps are implemented, from identifying the stakeholders to training the providers and finally monitoring the complications and outcomes for your patients. And with that, I think it's possible for anyone at any institution to successfully implement REBOA to save our patients that are suffering from non-compressible hemorrhage. And with that, I will finish, and I thank you all for your attention.
Thank you, Laura, for your guidance with implementing endovascular techniques and REBOA in Russia. And so there have been a burst of REBOA placements in the US when low-profile catheters appeared on the market. And so there are no low-profile catheters available now in Russia, and we still use catheters compatible with 10 French or more. So what would you recommend us to do? To wait until 7 French catheters appear, or we can use these 10, 11 French devices?
It's a wonderful question. So we do have low-profile devices in the U.S., but when we started our REBOA program, we were using the CODA device that went through a 12 French sheath. So my initial REBOA experience was with the 12 French device. The smaller, lower-profile devices are certainly a lot easier to use, but again, with training, you can identify providers that are able to do the 12 French device. So I wouldn't wait. There's always going to be newer, better, faster, slicker things that come out as technology improves, but work with what you have, and again, just make sure that you're safe when you're doing it. But 12 French sheath, it wouldn't stop me from doing it. It didn't stop us in Houston, and it shouldn't stop you in Russia.
So I'm proud to be a co-author of this paper on pitfalls, but it's a pity that I'm a co-author of complications paper. And is it related, I mean, the size of the catheter and the size of the sheath related to complication rate?
Yes, so in our experience in Houston, the 12 French device had a higher rate of complications, but we still didn't have any ischemic limb loss complications. So I think that's just the nature of the beast. When you're using a larger sheath, you're going to have more complications. The key is to recognize them and identify them early and treat them so that you don't have ischemic complications. The other thing that we've seen, even with the lower profile devices, is that your puncture site has got to be in the common femoral artery. If you stick too low, you're going to really increase your risk of having, either a dissection or a distal thrombus that forms. So again, being vigilant about monitoring early, I think, is really crucial, no matter what size sheath you're using.
I would like to be controversial. This is a scientific meeting, so our role is also to take, or my role now is to take the negative data. Some people are very skeptical about Reboa, and I know in the US, maybe you can tell us a bit, there are people that are very against it. And I'm sure there is a reason for this, and we saw Professor Belal Joseph's article with the negative results and Dr. Nori's results, negative results from Japan. Can you tell us your thoughts and how do you take this? How would we should learn from these negative results? What's your opinion?
So those are great points, and I agree controversy is good to stimulate discussion. So with regard to the Joseph paper, there were a lot of methodological flaws with that study. It was retrospective data from a very large national database, and it did not include data from really high-volume Reboa institutions. So for example, Shock Trauma Baltimore, none of their patients were included in that analysis, and so I think you were looking at a collection of data from very small volume centers that tend to maybe not have the best outcomes or are very early in their learning curve. So the comparison, I think, is a little bit difficult. So I think that data is useful in the sense that it gives us an idea of some of the flaws with our retrospective data to help us plan our prospective studies. I think the thing that we still need to do, and we're trying to do, but it's hard, is identify who's the best patient to get a Reboa. Should we be doing it in patients that are in arrest? Do we just do it in patients that have refractory hypotension? Do we do it in both and realize that outcomes may not be great for our arrest patients? But that's what I think we're struggling with still in our US and our current clinical question really is who gets Reboa, who's the best candidate in terms of risk benefit of the expense of the procedure, the expense of the resuscitation versus doing nothing and just saying this patient's in a blunt arrest and their mortality is very high and I'm not going to do anything.
Thank you. Yosuke, your question, please.
Thank you for the great presentation, as always. I'm Yosuke from Japan. Best course is absolutely well-organized, great course, but to start the reward, clinical experience to get the arterial access is essential. So how do you give the young or the resident to get the arterial access in trauma cases or in elective cases?
So that's a great question. Access is really important. Everyone understands that early arterial access is really critical to success for anything that you're going to do endovascularly. We put very early aggressive arterial lines in our trauma patients and in our non-trauma shock patients for monitoring purposes. So I think, training residents and having them do it in, critical cases in the emergency room as well as in the ICU on how to do quality ultrasound-guided common femoral artery access is really, really important. So when they do have the Reboa patient that comes in, they feel comfortable with that initial part of the procedure, which is getting the access.
Thank you, great to hear. And I also want to recommend to use ultrasound routinely, hopefully. Thank you.
Any comments, questions in Russian or in English? Because I have one. Just comment or a question. I just spoke with George Ostersen from South Africa, and he thinks he will use it in 1-2 cases a year or something like this. And then, again, just to be provocative, in the huge Houston, very, very professional center, you use more. In Sweden, we have much less trauma, but we are not as well trained in trauma, so maybe we need it more. Can you reflect on this? Is it just enthusiasm, or these patients really need the Reboa? I'm sorry I'm provocative, but I want to
That's a great question. Well, obviously, I have great enthusiasm for Reboa. I was a very early adopter of it in the U.S., and I think some of my partners are more enthusiastic than others. So you do see variation in practice depending on sort of who's on call and who is there. And I also think the patient selection. So, arrest patients, I think, are a great population to talk about, because if an arrest patient comes in, some of my partners don't feel comfortable doing a Reboa. They would rather do a resuscitated thoracotomy because that's what they're comfortable with. I like to do Reboa in those patients. Who's right, who's wrong? I don't know that there's a wrong answer, but it's about what you're comfortable with. And so I think if you're in a lower volume institution, putting an arrest patient on Reboa might be more difficult because the access is more challenging, which again I think just brings up the point of early arterial access will get you a long way in being successful in implementing Reboa. Even if you're not going to use Reboa, early arterial access just for monitoring I think is important. And getting good at that piece can be done outside of the dying trauma patient. And I think low volume institutions need to practice early arterial access safely as a part of their Reboa routine.
Any comments from the panel? Any comments on this issue?
So,
1 minute.
congratulations on the presentation. I have a question because Reboa is coming to Russia and someday Reboa is coming to Brazil. We still don't have the official catheter, the Reboa, but I know some colleagues who are doing some cases with CODA catheter in São Paulo and in Rio. But I'm afraid because this catheter, it doesn't have the right tip to go blind without fluoro, without the guide catheter. So I'm afraid they don't have as much good results using this improvising catheter. So the question is, do you think we should wait for the right material, the right catheter, or this improvisation with CODA and other kind of balloons? We should do
fast.
that.
I'm sorry, just a fast answer. Okay. We have to go.
Yeah, so I think great question. I think we safely used the CODA for probably our first 35 or 40 Reboas we did in Houston using the Amplatz wire. We did not use fluoro, but we did use digital X-ray. So we confirmed wire position before we did anything. So I think doing it blindly is potentially dangerous. And so if you're going to use a larger device, I think if you don't have diagnostic capability for digital X-ray, it may not be the safest thing to do for the patient.
Thank you. Let's reserve the question after, if it's okay with you, to the next speaker, Professor Jim Manning from the US. And I'm sure we can discuss it after his talk and in the rest. Thank you very much, Professor Moore.
Good morning. Thank you to the organizers for the opportunity to be here. It's wonderful to be here in St. Petersburg. Thank you very much. So I'm going to talk about endovascular resuscitation and try to answer a series of questions about this technique. And I will start. Okay. So I begin with just disclosures, is that I've got some funding to do research on this from the U.S. Department of Defense, and I also started a company to try to help advance this technology, and there are patents that are part of the University of North Carolina. So those are my disclosures. So the first question is this endovascular resuscitation, probably not the audience necessarily have to explain why to, but we do have a big issue in that. And I'm a resuscitationist, I'm an emergency physician by training, and so I am most interested in those that actually progress all the way to cardiac arrest. So the most severe of our patients, both of those for medical cardiac arrest and also those with trauma. If you just look at the numbers in the United States alone, we have 600,000 cardiac arrests a year in the United States. 400,000 of those are out of the hospital, so that's a huge number. If I focus specifically for this conference on those that are traumatic cardiac arrests or hemorrhagic shock-induced cardiac arrests, 60,000 people die of hemorrhage each year in the United States, probably a similar number in Europe, and I would imagine similar, maybe more here in Russia. And 50,000 of those are due to hemorrhage due to trauma. The survival rates are very low, as I think we all know, and the death rate leads to the loss of millions of lives, of potential lives, years of life. Among those, this is true for both military and for civilians, that 60% of those patients, the patients who actually have survivable injuries, 60% of those die simply due to uncontrolled hemorrhage. So this is an important problem that we need to try to address. So what is it that we have available to us in managing these? I'm very excited about this personally, is that we are in this endovascular resuscitation, extracorporeal perfusion era in which we are using these endovascular advanced techniques to try to save our patients. And they started in two directions. Certainly we're hearing a lot here about the endovascular hemorrhage control and trauma that really began with Reboa and balloon occlusion. But also on the medical cardiac arrest side, there's the use of extracorporeal perfusion, ECMO, or extracorporeal life support for management of cardiac arrest. And these two are steadily coming closer together and they're beginning to overlap and giving us what we might call an interventional toolkit that we can use for the management of these patients. Now, among these certainly is resuscitative endovascular balloon occlusion of the aorta. I think everybody here by now knows what Reboa is. If you didn't before you walked in the door, you do now. And so this is a technique used for hemorrhage control, and certainly it has the two locations. You either use zone 1 Reboa for hemorrhage below the level of the diaphragm, zone 3 Reboa for those hemorrhage that's isolated to the pelvis. And it functions by, one, hemorrhage control by the balloon occlusion, but also by supporting systemic vascular resistance and supporting mean arterial pressure. That's how it works. Now, extracorporeal life support, or ECMO, you may be more familiar with, is the use of femoral veno-arterial ECMO in profound hypotension or cardiac arrest to support resuscitation, or even in cardiac arrest, what we call extracorporeal CPR. And so this has been popularized. Probably the most famous picture of this is the SAMU in Paris, who are actually putting a patient on ECMO in the Louvre. And so what you're tasked with here is making sure that you get one in the Hermitage, okay? That's the next thing. Now, what I have spent my resuscitation life working on for many years is a technique called selective aortic arch perfusion, which is it looks a bit like a hybrid between Reboa and extracorporeal life support. Selective aortic arch perfusion involves taking a large lumen balloon occlusion catheter, passing it from a femoral artery up into the thoracic aorta. By inflating the balloon, you have thereby, as quickly as you can, isolated the vessels to the heart and the brain for perfusion during cardiac arrest. So even though with the balloon catheter there, it looks a lot like Reboa, it is primarily a perfusion therapy intended to be used to perfuse the heart and the brain during cardiac arrest. And it is amenable to both medical cardiac arrest and traumatic cardiac arrest. There's a series of steps in this selective aortic arch perfusion where you would start with an oxygen carrier you would take with you into the field and then perfuse that into the heart and the brain up to some point. There's going to be a volume limit in a medical cardiac arrest. In a trauma cardiac arrest, less of a problem because they're hypovolemic. We need to fill the tank. But after initial exogenous oxygen carrier, you then get venous access, begin to draw off the patient's own autologous blood and oxygenate it, reinfuse it. And I call this autologous blood sap, but it looks an awful lot like ECMO just to your aortic arch. If the patient reasonably stabilizes, fine, you can stop. If not, you can let the balloon down after return of circulation and give partial support up to maybe about 1 liter a minute until the patient either stabilizes very quickly, or if they need ongoing support, it acts as a bridge until you can get the larger cannulas in to do full body veno-arterial ECMO or ECLS. So that's the concept of SAP. And fundamentally what I think of SAP as being is as a stepwise approach, a sequence of steps that you can use to all the way up to full eCPR or full body ECMO only if needed. So that's fundamentally my concept, is trying to get to the patient, escalate the care to the level of that the patient actually needs, but not go any further than that if necessary. Because if you put somebody on ECMO or ECLS, they generally don't come off in an hour. They're likely to be on it for several days. So this is a way of trying to provide that support temporarily and then allow them to come off. Now, let's move along to some other questions here. So which of these techniques should we actually use? And it really depends on the patient. Where is the patient along the spectrum of decompensation? Those patients that are earlier in the decompensation, if they have hypotension, tachycardia, they're not responding to typical therapy, and they need hemorrhage control, the ones toward the low perfusion side, more here to the left, are the ones that are really the ones who probably are best for Reboa. The heart is still beating, you can get the balloon catheter in, get hemorrhage control, intravenous blood and fluids, those will do well. As you get into those that are more profound hypotension, heart rate variability, they may be actually about to crash or the impending cardiac arrest. Here's where you get into those patients that are maybe more amenable to something like SAP, where you can actually use perfusion support. Because if the heart stops beating, perfusion support will be helpful, and that's where SAP really helps more toward the true cardiac arrest end. So it really depends a lot on the patient, and it also depends on what kind of equipment and stuff you have. This is just a schematic that roughly sort of says, this is how I think these could fit together in uncontrolled hemorrhage. Again, if you've got a beating heart, hypotensive, you can use Reboa, get hemorrhage control, IV fluids. If they're already in a cardiac arrest, maybe go straight to selective aortic arch perfusion, which we'll hopefully have out in a year or two. If the patient's unstable otherwise, they can go on to extracorporeal life support. Or the technique I really don't have time to talk about is this emergency preservation resuscitation, which is profound hypothermia, then taking the patient to the operating room. There may be patients still, despite all of these endovascular therapies, where thoracotomy is really the best therapy. And these are things we will sort out as we better understand how to perform these techniques and have more clinical experience. Now, how? How do we do this? You just got a wonderful presentation on this from Dr. Laura Moore. I would say probably the most important thing to say is that the organization of this is key. You have to be able to have the trauma team organized to be able to perform this. They need to be trained, they need the equipment, they need all the resources. Your emergency care system, however that is, whether you have an emergency department, whether you have pre-hospital physicians, you need to organize that emergency care either to provide these techniques or to recognize those patients, identify them, which ones need to get to the hospital faster to be able to get this done. And an important aspect that's true of anything is if you really want to, in critical care, making a difference, it's got to be an intact system all the way from the point of injury all the way through the hospitalization. You can't just do something really sophisticated in one area and not have all the other care that's required. So we have the knowledge, the capability, the technology, but what we really need to do is actually organize this very, very carefully. I was talking with Pierre Carly, who's the director of the SAMU, where they do ECMO in the field. When I was last there, they did a pre-hospital emergency delivery, they did a C-section in the field. And I was asking him, I said, how do you do all of this? And he looked at me and said, it is not a matter of knowledge, it is a matter of organization. And what he meant is certainly the knowledge is important, but we have all of that knowledge. We have all those skills. We have all the techniques, technology. What we need is the organization to apply these in a way that can actually help save our patients. When should we do this? The bottom line is that in appropriate patients that need these endovascular therapies, we should do them early. These are not last-ditch minute efforts. We often in the United States would do thoracotomies on trauma patients as the last thing we did after everything else failed. That's not really the best time. For those patients with non-compressible torso hemorrhage, this should be done, Reboa should be used early. The earlier you use Reboa, the more effective it will be. If you wait until they're in a cardiac arrest, it may be effective, but it is likely to be much less effective than if it is applied earlier when the heart is still beating. For those in cardiac arrest or impending cardiac arrest, maybe Reboa or maybe SAP, what I've worked on. This may be, that perfusion may be helpful. If they're in a true cardiac arrest, you really need perfusion support. So SAP or ECLS, some combination of that with Reboa is probably the best way to go. Where? Well, when sort of, it leads to this. We need to get to these patients as fast as possible where they are dying. If that means if it's in the trauma bay or the emergency department, the operating theater, the hybrid suite, wherever that is, that's where we need to be able to apply these. But it also means that we need to be able to apply these therapies potentially in the pre-hospital care setting, in our civilian populations, maybe on the battlefield. We need to get these therapies out to these patients where they are dying as fast as possible. Just as this is an example where I was with the SAMU in Paris and they're putting a patient on ECMO in a train station. So if this can be done, if you can put somebody on ECMO in a train station, I would say all of us in here, we can manage to do some pretty sophisticated things outside the hospital setting. And the last thing to address is, well, who should be doing this? And the bottom line is that there are a lot of us in this field that we could all be lumped together as resuscitationists. We are the people taking care of these critically ill patients trying to save their lives. And it should be anybody that's in a resuscitationist specialty, or if this is part of what you do, trauma surgeons, vascular surgeons, certainly our obstetrical surgeons if they are taking care of these catastrophes that can occur that are obstetrical. Emergency physicians, the critical care anesthetists who are in the field, and anybody that works in the pre-hospital care setting. If you have the capability, we should be able to take these technologies and move them into the field to try to save these patients. So any of us that fall into the category of resuscitationists, we should be doing this. So in summary, we're doing this because we have poor outcomes in a lot of our patients. We can save them with the techniques that we've mentioned. How to organize this is really the key thing, is to put it all together, when, as early as possible, wherever the patient actually needs it, and by whom? By all of us in this room and anybody that considers themselves a resuscitationist. Thank you.
Thank you, Dr. Manning. Excellent presentation. You know, the term endovascular resuscitation is quite new for us, and I don't know how it can be even translated, but now during this conference we have a lot of Reboa catheters, and you have selective aortic artery purine catheters, so you can safely visit the Hermitage. So, and so let me ask you one question about oxygen carrier. You use it during selective aortic arch perfusion. Is there some evidence behind it to prove this use in a human being? What about, because as I know, oxygen carriers, they're not as effective as blood. So what's your comment on that?
Yeah, as far as for the oxygen carriers themselves, right off the bat, it's hard to beat Mother Nature. I mean, nature gave us blood, and it's the perfect thing. But in a reality, in resuscitations and stuff, we won't always have blood exactly the way we want it. The oxygen carriers that exist have benefits, and they have certainly concerns and limitations. Some of the hemoglobin-based oxygen carriers that exist are really quite effective as a bridging tool. They do not replace blood, but they could potentially be used in the early resuscitation when the patient's still bleeding to act as an oxygen bridge, you might say. And so one of the ones that I've worked with is a hemoglobin called HBOC201. It's proprietary, but I've used it a lot in the laboratory, and it's very effective. I mean, we've been able to use it very effectively, and it's actually been used quite a bit clinically. And it may not be too long before we actually have it approved more widely than, say, just South Africa and a couple of other places. But and I'm not sure it may even be approved here in Russia. I think at one point they were trying. But the hemoglobin oxygen carriers or fluorocarbons are not as good as blood. But for the initial resuscitation, the initial bridging that we need to do to get the patients to the operating room, I think they can be adequate. And the good thing is that they can help us not waste resources, because if you have 40 units or 100 units of blood, that's great, but you really don't want to waste blood unless you need to. So if you could give an oxygen carrier with this technique, get the patients to the operating room while they're still bleeding, let them bleed out the oxygen carrier, get surgical hemostasis, then begin to use that blood that's a more precious resource.
Is it used in reality, in real practice, in trauma centers?
And the HBOC201 has been approved in South Africa for many years. I know it's been used. How much it's being used right now, I don't know, but it has been used successfully. The HBOC201 is being used in the United States. It's used almost on a daily basis for Jehovah's Witnesses who are hemorrhaged, who refuse to take blood. And I know the company well. They tell me that they get a compassionate use request 2 or 3 times a week. And so it's stocked in various places in the United States just for that purpose, for compassionate use. They've used it in hundreds and hundreds of patients successfully. So it's not perfect. It has some issues, but it can be very effective at trying to save your life.
Thank you very much. One question here, please. Jaime Tisnado. A very brief question, if possible.
Good morning. My name is Jaime Tisnado. I'm coming from Richmond, Virginia, in the United States, and I think I would like to make a comment. Seems to be that Dr. Manning has presented a great talk about Reboa and all interventions, but in no place I saw collaboration from the interventional radiologists. I think the interventional radiologists and the surgeons, we must work together. As a matter of fact, in his institution, the Department of Interventional Radiology is a great one, and the chairman of the department, Dr. Moro, he's one of the most famous interventional radiologists in the whole country, and I don't see any collaboration with you, with the surgical department. And I think if we want to help the survival of the patients in trauma, we need to be together between the interventional radiologists and the surgeons. Many times we don't need Reboa. As a matter of fact, in my institution, by the way, and I've been in trauma intervention 50 years, so I know what I'm saying. As a matter of fact, I wrote a book just not too long ago in trauma. I think I would like to foster the collaboration between interventional radiologists and surgeons for the benefit of the patients, and I don't see too much mentioning here of interventional radiology in this situation. Thank you.
Thank you, Hami. Thank you, Jim. Thank you. Okay. Would
me
you like to comment on that?
My only comment is that Dr. Morrow, who you mentioned, has been a friend and colleague for many, many years. We even did martial arts together. That's how close we are. So, I agree with you completely. I'm not trying to leave out the interventional radiologist at all. I'm mostly focused on probably being an emergency physician, getting the patient alive to the surgeon and the rest of the team. When I mentioned that you need to have everything intact, all the system, that in my mind includes the interventional radiologist. I just didn't have time to really kind of mention that.
Thank you very much, Jim, and thank you. Спасибо всем большое. На этом наша
Thank you so much, colleagues, and we have depleted the agenda of this session. Thank you so much. A coffee break now. In the exhibition area, you may have a look at our sponsors' products. Thank you so much to them. Aleph is our general sponsor, and we have official sponsor and participant of the exhibition. Please come up, have a look. We have different balloon catheters, Japanese, Russian, etc. You may have a look and you may see the poster session. It will officially take place during lunchtime. And the books, the top stand that was mentioned by Tal Hora, it's available on the stand. You can buy them if you want. Please have a look. Thank you.